quite a huge proportion of my patients have underlying diabetes, hypertension, and also high cholesterol. And I've had patients as young as years old with premature coronary artery disease.
When you talk about heart disease or coronary artery disease, you know there's many driving forces behind that. It can be high blood pressure, high cholesterol, diabetes, and overweight. And these are factors that we must definitely tackle so they can reduce the risk of developing another heart attack. I would like it if the patient had not seen you in the first place. I would like to see the patients 20 years ago.
Dr. Chiew Ken Seng, consultant endocrinologist and internal medicine physician at SJMC. Dr. Chiew manages a wide range of metabolic and hormone-related conditions including diabetes, obesity, thyroid disorders, and other endocrine issues. Dr. Thurston Erng, consultant cardiologist at SJMC with a focus in interventional cardiology. He performs everything from coronary angiograms and angioplasties to complex coronary interventions and structural heart procedures. In Malaysia, heart disease remains the top killer. And more than half of adults are overweight or obese with high rates of diabetes, high blood pressure, and high cholesterol. Hi, my name is Leonard and welcome to Let's Talk About, a health podcast by SJMC. So I want to start off today's conversation really with understanding who comes to the clinics these days, right? And when it comes to heart problems, I think we can all agree very familiar with the older population, retired folks presented with heart concerns. But there's now new cases we hear all the time that younger people are coming through the door. I guess to Dr. Thurston, right, is this something that you see as well? And perhaps could you share maybe what are some of the youngest patients you've seen so far in your practice?
Well, this may be interesting to you, but the youngest patient I've seen with coronary artery disease is 19 years old with a heart attack.
Oh, wow.
Yes, indeed, isn't it? Well, many people think, because I'm young, I'm protected. I can't possibly have coronary artery disease. Now, let us understand that coronary artery disease is a complex condition that can be affected by multiple risk factors. Now, of course, the young population with coronary artery disease may have certain predisposing factors, particularly high cholesterol incidences, and some of these may be genetic or familial in nature, and therefore if you don't look out for it and you're not conscientiously testing yourself, screening yourself for it, these may be risk factors that can be managed but not done in terms of preventive actions.
Right. So for young patients like that, the 19-year-old, right, did she already have a heart attack before she first came and see you?
So the patient was a male patient presented with a heart attack.
Sorry, so the male patient, so that 19-year-old patient came with a heart attack.
Yes.
Right.
So that was the first presentation, and from that presentation, we worked out the fact that he had very high cholesterol levels. And in fact, we did something what we call cascade screening, where we screened other family members and realized that there was a whole group of them or members of the family with high cholesterol levels that needed treatment.
So, you brought up a very good point, which is health screening, right? And for young folks today, right, listening in, they are clearly, from what you're just telling me, they are not immune to these woes, right? And so when it comes to health screening, and maybe Dr. Chiew can just chime in a little bit, what do you think are some of the key things that young Malaysians, young people should look out for so that they can prevent, a really early onset of a heart attack, for example?
Yeah, I agree, Thurston. I think a lot of times we think that just because you're young, you're protected from all these form of non-communicable diseases. But actually, not detecting it doesn't mean you're protected from it. In fact, you're at risk because you're doing nothing about it. So a lot of studies have shown that a lot of our hypertension, diabetes, and dyslipidemia or high cholesterol is actually undiagnosed. So a big proportion of our type 2 diabetes is actually undiagnosed, especially in the younger populations. In those aged between 20 and 30 years old, up to 70 to 80% of them do not know they actually have type 2 diabetes. Yeah. And just because I'm an adult endocrinologist, so I see patients above 12 years old, my youngest type 2 diabetes is actually 13 years old. Yeah. So just because you have no symptoms doesn't mean you're protected. And diabetes is something that does not cause complications overnight. The moment you have found out that you already have diabetes, the damage might already occur a few years before that. Yeah. So won't be surprised that, when you already just diagnosed type 2 diabetes, yeah, but you actually already have complications such as eye damage or kidney damage. So I think it's very important to remember that screening, should not be neglected just because you're young. And detecting it early, having a disease early, does not mean that, it's something bad. To me, it's something good because you can tackle it and treat it earlier.
Right. So in fact, would it be fair to say that if you are younger and you detect a problem, a health problem, right, are the odds of treating it, are the odds of resolving it better compared to, let's say, getting it at your 50s, for example?
Well, perhaps I wouldn't use the word resolve because we're talking about some of these chronic, long-term conditions, non-communicable disorders, but they certainly can be managed. Now, if I were to talk about cholesterol, I think just to echo what Dr. Chiew has mentioned earlier on, he mentioned with diabetes, people are not aware of the fact that they have diabetes. Cholesterol, for instance, high cholesterol levels, depending on which survey you look at in Malaysia, a quarter to half of the patients with high cholesterol do not know they actually have that problem. Now, with cholesterol, the most important thing, and it's been proven across the board, that what we call the bad cholesterol, LDL cholesterol, it's proven to be atherogenic. In other words, it causes the formation of plaque within the vessel wall, and that can be in the limbs, in the coronary arteries of the heart. And studies have also proven that the earlier you control or manage your LDL level, in other words, the lower and the shorter your exposure to high LDL levels, again, LDL is the bad cholesterol, then over time, the lower is your risk of developing heart attacks and cardiovascular disorder.
Right. So to the young Malaysians listening in today, do not omit your house screening. And if something goes a little bit awry in the report, it doesn't mean the end of the world. We can certainly manage it well. So I want to take one step back and think about maybe one major problem here in Malaysia, which is obesity, right? Now, we talk about a young patient, but what if a obese individual comes into your clinic and they see you and they have shortness of breath and some chest pains, right? Is the treatment likely to be very different from, let's say, a young patient that we mentioned just now?
Yeah, the first point to understand in that context is this: overweight or obesity itself is a major and an independent risk factor for cardiovascular disease. So certainly I'll be very concerned upfront when he or she who's overweight presents with certain symptoms that requires further attention. Now, primary to that is whether there is already a form of cardiovascular condition, and that can range from coronary artery disease to even heart failure or dysfunction of the heart.
Right. And with the risk factors that an obese patient presents, right? We hear this term of metabolic disorders, and just to help the public understand that a little bit, what are these metabolic disorders associated with obesity, overweight? How serious is it actually?
So right, when you talk about metabolic disorder, it means that the body is unable to process, certain materials such as your carbohydrate properly. So when you have excess body weight, before that, I think we should define what is overweight and obesity. So traditionally, we use the definition by the World Health Organization. We use a cutoff of a BMI of more than 25 kgs per meter squared. But we realized that in the Asian population, we are predisposed to complications of excess fats even at a lower BMI. So hence, that is why when we talk about overweight, we use a lower cutoff point of 23 kg per meter squared for Asian population, including in Malaysia. So the scary part about it is if we use the cutoff of 23, 7 out of 10 Malaysians are at least overweight to obese. And that is so common, yeah? And I think obesity and overweight is a driver for all those metabolic conditions that we talked about, because when you talk about obesity, you're talking about increase in inflammatory markers in your body, increased risk to develop those non-communicable diseases that we talked about, such as diabetes, hypertension, and high cholesterol. And this, over a period of time, will lead on to more damages to your blood vessels and subsequently heart attack, strokes, and as well as kidney damage. So we have this term that doctors nowadays we coined, which is called a cardio-kidney metabolic syndrome, whereby if a few stages, just to reflect how all these things arises from excess body weight and subsequently those complications that we mentioned about.
So you mentioned briefly about metabolic disorders, overweight, then ties into heart diseases, right? So going back to that obese patient, typically then what happens, right? When an obese patient with that kind of symptoms comes up, what is the next step for that patient when they come and see you?
Yeah, I think the primary thing, of course, with every consultation is to understand what's the nature of the symptom. What exactly does the patient mean by shortness of breath? Is it on exertion? Is it at rest? Does it come at night? Is it triggered by certain food? Is it triggered by certain actions or at certain time points of the day? So that's number one. Likewise, with the chest pain or chest discomfort, if he or she has that. Now, the next step, of course, to do and evaluate that in a sort of more objective manner. Commonly for a cardiologist, we would advocate for an electrocardiogram or an ECG to look at the baseline heart rhythm. I might also suggest for the patient to undergo a test called an echocardiogram, where we do an ultrasound scan of the heart to evaluate in terms of the heart structure, the heart size, and particularly the heart muscle wall, because obesity is known to be a driver for heart dysfunction, which I mentioned earlier on. And some of these manifest in terms of what we call cardiac remodeling. And that's to say that the heart undergoes structural changes to adapt to the excess weight that it has to sort of carry, if you like. And this results in whether thickening of the heart muscle wall or what we call diastolic dysfunction. Now, if you could just elaborate that a little bit. So commonly we think of the heart as a pump. So we think of whether the heart is strong or not strong. That's in terms of its squeezing effect or pumping action. But the heart also has to be able to relax properly in order for it to work. So we know in some of these obese patients, it is in what we call the diastolic dysfunction part. That's to say that the relaxation component of the heart muscle is not as good as compared to a normal person. So in many ways, obesity can result in heart problems, and this has to be objectively stratified or evaluated. And of course, the next step is if the symptoms fit into some concerns with regards to coronary artery disease, then we may advocate for a patient to do maybe an exercise stress test or even a CT scan of the heart, and depending on the findings from these, further examinations as necessary.
Right. So let's assume the findings shows there's a blockage, right? What happens next? Does this mean surgery, or what happens to the patient?
Well, blockage commonly is people are just concerned. Oh no, do I have blockage? And if I have no blockage, then I'm fine. But again, I think I'd like to reiterate the point that the heart can be affected, particularly in the context of obesity, in many ways, not just in terms of blockage. But in the event of blockage, a few things need to be evaluated. Number one is, of course, the severity and the location of blockage. If it's a more proximal location, that's to say it is further up in the blood vessels and of greater degree in terms of its narrowing, then that's of more concern. And sometimes we will advocate for procedures in order to relieve that narrowing. And that may be in the form of an angiogram, plus minus a ballooning or stenting procedure in order to relieve the narrowing. But also importantly, in current and modern day cardiology context, it's important to understand that not all narrowings need to be opened up in common language, or ballooned or stented in common parlance. What we can do in some of these situations where the narrowing is kind of intermediate is to do more detailed analysis of the narrowing, what we call physiology-based decision, where we put wires and we measure pressure differences from the inside, and we make a decision whether a narrowing needs to be corrected.
Right. So let's assume a blockage was detected, we've resolved the issue, right? Does that mean the patient's fine and dandy, they can go back to life? Or are there things that, the patient has to do to prevent another blockage or a heart attack from happening down the road?
So it's interesting you use the word resolve. And it's important for us to realize that whilst cardiologists may be able to open up the narrowing, so to say, with an angioplasty procedure, the disease process does not end in that context. Once the plaque forms, the plaque never disappears. The procedure in terms of ballooning or stenting addresses the flow issue. It improves the flow. of the coronary arteries, but does not completely remove the underlying plaque deposits within the blood vessel wall. Now, quite a huge proportion of my patients have underlying diabetes, hypertension, and also high cholesterol. And this is where sometimes I enlist my good colleague, Dr. Chiew, an endocrinologist, to help me manage the patients in the long term, because these are the driving factors that result in sometimes re-narrowing of the coronary arteries.
So when you talk about heart disease or coronary artery disease, you know there's many driving forces behind that. It can be high blood pressure, high cholesterol, diabetes, and overweight. And these are factors that we must definitely tackle so they can reduce the risk of developing another heart attack. But, I would like it if the patient had not seen you in the first place. I would like to see the patients 20 years ago. Why? It is because when the heart attack and the damage has occurred to the patient, it is something that we cannot reverse. We try our best to prevent it from happening again, but the damage has already been done. I get very sad when I see patients with diabetes who had already developed, stroke, renal damage requiring dialysis. Because I know I can control their diabetes, we get beautiful numbers, but I am not able to reverse those damage done to their body. I prefer to treat them earlier, maybe 20 years ago, when they were just diagnosed with diabetes. So when you talk about diabetes, do you know that we can actually, reverse, but the more accurate rate is actually called diabetes remission. Yeah. So when you talk about diabetes, there are two components to it for type 2 diabetes. There's a component called insulin resistance, whereby the insulin does not work very well. And one of the drivers for this is actually because of the excess body weight. Yeah. And the other reason is because the pancreas does not produce enough insulin. So as you can see from the pathophysiological point of view, if you are able to reduce the insulin resistance due to excess body weight, you can actually reverse the diabetes. Of course, the right term is diabetes remission. So, for example, I have a patient with a HbA1c of 11%. So HbA1c is the average sugar for the past 3 months. So you would like to keep it below 6.5%. Normal people is even lower, it's 5.7%. So my patient actually worked very hard in terms of weight loss. He lost 20 kilos over the next 6 months, right? He was heavier than me. Now he's thinner than me, right? And the most amazing part is, take a guess. What do you think his HbA1c is now?
Normal at the very least?
Exactly. 5.6%. A normal HbA1c, not only to target a normal person's sugar level. And the most amazing part is when I tell the patient, I can now stop all your diabetes medication. That is what we like to achieve when we manage young people with diabetes. Not only just to control diabetes, but to help them achieve diabetes remission. So, when you detect diabetes early, this is when we can do all these things that we mentioned earlier. Yeah. Of course, when you already develop complication diabetes, we'll try our best to manage you. But, the satisfaction is not really there because the damage has already been done. So don't be afraid to get yourself screened early. If you detect problems earlier, take it as an opportunity to do those interventions that we mentioned about earlier.
Right.
Yeah.
I think that really emphasizes the fact that really, even if you're young, health screening can save you so much hassle down the road. If you're young and you get detected with a chronic condition like diabetes, intervention can happen, right? I do want to then ask the both of you from both your practices, because you always think of people with heart conditions, then with diabetes as well. Typically after an intervention, and we're trying to minimize the reoccurrence of another heart attack, for example, how successful are we at the moment? How successful are patients that are, obese able to prevent another reoccurrence of a heart attack? Is this something that we are seeing positive results so far?
So I think whenever you already have a heart attack, your risk to develop a second heart attack remains elevated, but we try our best to reduce that risk by controlling those risk factors that we talked about. From my point of view, in terms of type 2 diabetes, there are actually medications that not only can help to reduce sugar, but also to protect the heart and kidneys in that aspect. There's a class of medications called SGLT2 inhibitors, whereby they make you pee out the extra sugar, to not only control your sugars, but reduce your risk to develop heart failure in the future, as well as to protect your kidneys. There's another class of medication called GLP-1RAs. These GLP-1RAs are actually medications whereby they mimic your intestine hormones to reduce your appetite. Yeah, so you can lose weight. But there are also studies to show that it is able to reduce your incidence to develop a heart attack in the future. So when we talk about diabetes medications, these are the two types of medications that I like to choose for patients with type 2 diabetes and heart disease to not only control their diabetes, but to help to protect the heart and kidneys in the long run.
Now, both endocrinologists and cardiologists are asking a different question. How do we collectively reduce your long-term risk? Not just numbers. And this is exactly what Dr. Chiew had mentioned. So when we give therapies, when we initiate medications for patients, it's not just chasing the sugar number, the cholesterol number, but we're looking at what we call cardiovascular outcome. And that's to say, how do we reduce your risk of another heart attack? How do we reduce your risk of getting a stroke down the line? How do we reduce your risk of cardiovascular death? And in fact, in clinical trials, there's a term called MACE, Major Adverse Cardiovascular Events. And the two classes of medications that Dr. Chiew had mentioned earlier on, SGLT2 inhibitors and also GLP-1 RAs or receptor agonists, have some data with regards to improving overall cardiovascular outcomes, not just controlling diabetes.
So at the end of the day, when we want to prioritize change, especially for listeners in today, let's say they know somebody who has gotten a heart attack, right? And we're providing and lending support. What are some of I think you've alluded this a little bit, some of the major changes people need to prioritize so that they reduce their risk for a reoccurrence? I think you mentioned diabetes. Is that the only thing?
There's actually a collection of risk factors to develop heart disease. So number one, you need to get your blood pressures under control. So there are certain blood pressure medications that you need to be on. One of the class of medications they like to use is called the ACE inhibitors or ARBs that can protect the heart. Then cholesterol medications, usually in the forms of something called statin, to control that. Diabetes will be those medications that we talked about earlier. Then if the patient has excess body weight, after the heart has stabilized, we would like it to lose some body weight to help to control those factors earlier.
Right. So blood pressure, blood cholesterol, your diabetes, and weight is the main things that people should prioritize.
Yep.
So in today's day and age, we then now hear when it comes to weight loss, Ozempic, Wegovy, Mounjaro, right? What are these medications and are they safe?
Right. So these medications are basically to mimic the hormones that come out from your intestine after you've eaten. So they give you a sensation that you're going to be full. Yeah. So this medicine basically is to help you to reduce those cravings so that you probably won't have those hunger pangs and snackings as often. And it's probably, as I said earlier, is to support the lifestyle that we talked about earlier to help you restrict your calories. And with that, you're able to lose your body weight.
Right. And 10 years ago, let's assume, right, were such drugs available? And how has the patient population sort of like shifted with the inventions of these new drugs?
It's funny you brought up the time point in terms of 10 years ago, because 10 years ago, I would struggle to talk to a patient in terms of starting some of these injectables, in particular insulin injections for control of their diabetes. But in current practice, I have patients coming in through my office door and asking me, Doc, is it possible or am I safe? Is it all right for me to go on some of these injectable medications from the class of the GLP-1 receptor agonist for the purpose of weight reduction and diabetes control?
Right.
Yeah, but I think it's also important for us to bear in mind that all these things have to be initiated in a safe and monitored conditioned, and because there are potential risks that comes with this. For example, there will be some data coming out, although this needs to be corroborated further, but there's some data coming out that perhaps GLP-1 receptor agonists may be associated with higher risk of inflammation of pancreas called pancreatitis. Now, the other aspect to be aware of is this: when you feel full, so what happens is that you eat less. At the same time, there are side effects from GLP-1 receptor agonists or GLP dual agonists, as you call it. You have nausea, you have vomiting. Some of these patients have abdominal discomfort, and these may result in volume loss or what we call dehydration and etc. So this needs to be monitored, and patients need to be aware of potential risk.
So I think I agree, Thurston. There are a lot of these medications, to be honest, quite freely available nowadays, even online. I would tell my patients, to be very careful. Do not buy these medications for unverified source because there are a lot of fake ones around, and you know how expensive it is, right? So if you see it's unusually cheap from an unverified source, be very, very careful. And best to take it under supervisions because of all those black box label warnings that we talked about earlier. And you know, when we talk about these kind of medications, we don't just initiate them. We talk about the potential side effect and ways to deal with these side effects. For example, nausea and vomiting is something that is quite common. Why, you know, you eat too full after a buffet, you feel like vomiting, right? So that probably, you know, you have that sensation over there. So this is very important when you are on such medications to eat slowly, drink lots of water. And the moment you feel full, you stop eating more so that you can minimize your risk of developing those nausea and vomiting. Avoid fatty food or very high carb food, as that can worsen that feeling of nausea and vomiting. So these medications are very helpful, but it is very important to do it under supervision, under a qualified medical professional, so that we can try to tackle whatever possible side effect or complications that might arise.
It's also perhaps important for me to mention that we do this in a titrated manner. We
Yes,
start
yes.
at a low dose and then we titrate up the dose at a tolerable dose according to the patient's profile and condition.
Yes. So there are a series of doses whereby we increase it gradually every month so that the side effect is much more tolerable. I've got very impatient patients who really want to lose weight. So, you know, instead of 2.5, doctor, can I straight go to 5? Instead of going from 5 to 7.5, can I go for 10? That's not very wise. You know,
I've had the patient come to me and say that, Doctor, sikit sangat lah berat badan turun.
exactly, yeah. You know, sometimes when I start the lower dose, they will tell me that, doctor, I don't feel much changes. But it's okay because these medications are to be taken for a longer term. I do not want to start you on a medication whereby you develop so much side effects that you hate and you do not want to be on those medications anymore. So don't worry, start slow, move gradually. You're gonna see the effects, with time. So don't just cold turkey and hit the highest dose. Start from the low dose and slowly bring it up under supervision of a healthcare professional.
You brought up an interesting point, which is you titrate upwards the dose. But is there at any one point where you do the inverse, you titrate backwards, and at one point do you go off the medications then?
Right. So that is a very important question, Leonard. I get these questions where, can I stop these medications? And to put things into perspective is like, for example, you've got high blood pressure. You don't just stop your high blood pressure medication. You probably take your high blood pressure medication for a long term. The point of view nowadays is that we view obesity as a chronic disease itself rather than just a lifestyle choices. Because sometimes it is not easy to lose weight despite all those lifestyle changes that we talked about earlier. So don't be afraid, don't be shy if you need a little bit help from medications, because what matters at the end of the day is your health, right? But we know that when we stop these medications, that hunger pangs, that cravings that we talked about earlier might come back. So it is very important, to reiterate the importance of lifestyle, those diet that we talk about, those exercises. I've got patients whereby, he lost a lot of weight. Very happy for him. And he's asked me whether he can try to stop those medications. After some discussion, I felt that he actually had put in a lot of effort on his lifestyle. And I think, actually, to be honest, I felt most of his weight loss actually came from those lifestyles instead. So I told him instead of cutting it off completely, let's do the reverse. So, for example, the medication 1 mg, I said, let's cut down to 0.5 and gradually bring down to 0.25. We maintain close contact. And again, every time I see him, reinforce regarding the importance of lifestyle. And fortunately, he has not rebounded in weight after weaning off those medications. So in general, I will view it as a long-term medication. It is possible to take a step back, but we need to do it carefully.
And then perhaps in other words is to say to everyone that weight loss, there is no magic bullet. You do need to put in a little bit of effort, and it can be laborious in nature. It's not just inject and I lose my weight and I'll maintain it as it is.
I think we've really established the fact that weight loss is really beneficial. Unfortunately, the way to get there is still hard work. Even with medications, it's a supplementary effort, but it does not represent a silver bullet. Enjoyed this episode? Like and follow us for more conversations like this. If you have a topic you want us to cover next, drop it in the comments. We'd love to hear from you. So I guess onwards to another segment, I think we've already alluded the fact that weight loss seems to be a very critical component in somebody's health, somebody's cardiovascular outcomes as well, right? But why is that really important? What's actually happening? Could you just help us understand that a bit more?
Right. So remember I told you how common overweight and obesity is in Malaysia? It's 7 out of 10. So you with 10 people in the room, 7 of them are actually overweight, yeah, or at least overweight to obese. So I think it's very related to not only our genetics, but also our lifestyles, yeah. So when you talk about being overweight or obese and type 2 diabetes, everybody always blames sugar. We know sugars are bad, but we underestimate carbohydrate as a driver for obesity, right? Because you go to your usual hawker fare, your char kway teow, your mee goreng mamak, your roti canai, your nasi lemak. What's in common in them, aside from them tasting good? There
High
would be-
carbs,
exactly,
very high
the
fats,
high
yeah.
carbohydrate, yeah. So, for example, you go for your mee goreng mamak, 90% of them are noodles. And because meat is expensive, you've got a few shreds of meat inside there, and a few shreds of vegetables inside there. And mostly it's carbohydrate, yeah. So I think we underestimate that. And carbohydrates are cheap, right? So obviously you're going to go for your, more balanced meal. It's going to get more expensive because the meat is more expensive. Vegetables are more expensive, right? So I think we need to realize that, carbohydrates should be taken in moderation. If we used to talk about the food pyramid, right? We put carbohydrate at the base and the meat is probably a little bit up. I think nowadays the guidance is a little bit different. Have you seen the inverted triangle by the US food and dietary advice? So I think carbohydrates has to go down a little bit. Focus a lot on high quality protein as well as also vegetables. So I think that's the way diet should be in order to help, you not to gain so much weight in that sense.
That's interesting because I remember growing up and, in a classical Chinese family, when you're not full, your parents say, eat more rice, right? And I see that with my Malay friends as well, right?
Yes,
If they are hungry, take more rice lah.
Yes.
But, interestingly, then you're suggesting that adds on calories very easily, it seems, right? And so if we change that about, are you saying weight loss can be a more achievable?
Yes, I am. So when I talk about dietary changes in my patients who are overweight and obese, I'll tell them that first thing first, losing weight is about how much you eat versus how much you burn. Right. So one of the ways to lose weight is to do something we call calorie restriction. So you limit amount of calories so that you burn more than you eat. So I advise them to do something called calorie counting. Yeah, you get a lot of apps nowadays available to help you calculate your calories. But basically, if you realize that if you're going to eat a more balanced food with more protein and vegetables, the calories are actually lesser. Yeah. So I think the key take-home message is you do not need to starve yourself to lose weight. You just need to choose the right food groups. Yeah. Of course, you don't indulge too much. Yeah. And you can probably lose more weight. So for example, rather than going for that plate of char kway teow, I ask my patients to go for mixed rice. Take a little bit of rice, a little bit more vegetables, and some amount of protein. You'll be quite full. At the same time, it does not contribute too much calories to your diet.
So I guess just to set the importance of the weight loss then, are there tangible benefits that we can drive home today that, look, if you lose the weight, there are real tangible benefits people can get?
Yes, definitely. So, as early as the next 1 or 2 months when you lose your body weight, you can see that not only you feel better, you can see your blood pressure going down, you can see your cholesterol level going down, as well as also you can see that the patients, have perhaps knee pain. You feel the knee pain is getting lesser. Yeah, the people who snore, you probably can see that quality of sleep improves. Yeah. How about you, Thurston? Do you see any benefits?
Well, absolutely. I mean, as a cardiologist, I always give the example of an excess weightage, transport vehicle. Imagine an overweight lorry or an overweight car. So if you lose weight, that's akin to normalizing that. And I mentioned this earlier on. If you're overweight, there is excess load and demand that the heart has to cater to. And if you remove that, there is some sort of normalization, reduces the stress on the cardiovascular system. And also, I think on the more sort of practical terms, quite often, I think Chiew and myself would have patients coming to us and say, I've lost significant amount of weight. I feel better. Exactly what you mentioned. I sleep better. I feel happier.
Yeah, correct. There's the psychology part. They feel more confident about themselves. They feel happier. I think that's something that we like to see in their patients as well.
Absolutely.
Yeah.
Right. And, we hear cases of the non-compliant patients with heart concerns, right? When somebody who has a pre-existing heart risk, that they've maybe gotten a heart attack before, if they lose weight, does that significantly change their likelihood of getting a heart attack again?
Oh, well, yes, absolutely. I think, again, it goes back to the fact that obesity or overweight itself is already a risk factor for developing cardiovascular disease. And certainly, if you have established cardiovascular disease, reducing weight is a key and paramount parameter for us to achieve. And also in terms of reduction of blood pressure or control of blood pressure, control of diabetes, control of cholesterol, all of these has been associated to be better if you are able to bring down your excess weight.
Right. So clearly, losing weight, if you're obese, if you're overweight, is super beneficial, right? But to manage expectations as well, right? You always hear the story of, oh, I lost 20 kilos in 1 month or whatever, right? Is that safe? Is that healthy? Is there a target that people should look out for?
Right. So generally, when you talk about weight loss, I think losing weight is difficult, but maintaining that weight loss is even more difficult. So I would put weight loss journey akin to a marathon rather than a 100-meter sprint, right? You can lose that 20 kilos, but can you maintain that 20 kilos weight loss over that many years to come, right? So I would prefer a more gradual approach that is very much more sustainable. I think perhaps in a week, a reasonable amount of weight loss that you would like to achieve is probably about 0.5 kilos to 1 kilos in a week, right? And you try to build that up, over a period of time. So when you try to lose like 20 kilos in one month, you're probably completely starving yourself. And can you really do that for the next, that many years? So I'd rather tweak your dietary lifestyle a little bit, cut down your carbohydrate a little bit so that, you still feel happy about yourself, right? I mean, everybody says food is a form of joy, right? I'm not going to deprive you of that joy. So just choose your food classes properly, control the amount of calories, and of course, put in some physical activity as well. So we always recommend people to put in something called moderate physical activity or some form of brisk walking, about 150 minutes per week. You mix that up with a little bit of weight and resistance because you want to build up some muscles. So muscles are metabolically very active, so you can eat up those sugar, and help to control your blood sugar and your body weight. So that is very synergistic with the food patterns that we talked about earlier. Remember, I told you to eat a little bit more protein, so that will help you build your muscles as well.
Right. So then comes the question of how do we get the weight loss done? And I think you've already alluded the fact that sustainability is going to be a really key component behind it. But I want us to have a bit of fun with both of you, right? What are some of the more interesting approaches that maybe might not be a good idea for listeners to try? Are there certain diets that are better than others? Are there certain ways that are perhaps not a really good idea?
So there are a lot of diets out there. I think one of the more popular one are ketogenic diets, whereby they deprive themselves completely away from carbohydrate, refined sugar, and things like that, and focus completely on protein and fats. I feel that diet is a little bit extreme from my point of view because that really drives up the cholesterol level, and I think in the long run it's not very good for the heart and the blood vessels. I would go to something more balanced. I would go for something more less extreme. You don't need to go for any specific diets, as long as your total calories a day is lesser than what you burn, probably about less than 1,500 for average size persons, and you go for more whole food. Try to avoid processed food because processed food are rich in things like salt and sugar. Processed food are easily absorbed by your body, so you spikes up your glucose. So go more for whole food. One example that I can give you is some of my patients with diabetes would say that they go for a lot of fruit juice. They think it's healthy. Don't get me wrong, fruit juices are healthy in the sense that they have a lot of vitamins and minerals, but you don't forget you're actually removing the fiber. So when you remove the fiber, when you drink it, the body absorbs that juice very quickly, and you can see significant spikes in the sugar. So to me, fruit juice is actually quite bad. I rather the patient go for natural fruits, eat it in its natural form. So I think that applies to a lot of food as well. The more whole and less processed the food is, the better it is. And of course, to control your calories, total intake for the day.
Right. And yourself, Dr. Thurston, have you heard of any interesting diets that...
So I think from the perspective of a cardiologist, some patients come to me and say that, I eat less. So it's not just about eating less per se, which is exactly what Chiew has mentioned earlier on. It's about eating right, getting your classes of food correct. And that's, to me, the gist in terms when you talk about diet.
So it sounds like, making sure that we reduce the refined, high processed stuff and eating more of the natural whole foods, which may make us feel fuller as well, which might help with the weight loss at the end of the day. So for our last segment today, I think you've already briefly alluded this, Dr. Chiew, on the necessary relevance of exercise, right? When it comes to weight loss and cardio, strength training. And just to get this conversation going, right? Maybe I can just ask this first question. Is exercise only for weight loss?
So that's not true. Exercise is not only for weight loss, but it's also for your own cardiovascular health as well. Yeah. So in general, I would like to recommend people to go for at least some form of moderate physical activity, which is at least the intensity of a brisk walking, to target at least 150 minutes per week. Why 150 minutes per week? Because there's evidence from trials to show that it benefits the patient's cardiovascular and metabolic health. So when you talk about 150 minutes per week, do a mixture of exercises. You would like some aerobic exercises, yeah, such as your brisk walking and cycling, to burn off that extra calories and fats. Yeah, you also would like to do some strength and resistance training to build some muscles. So a combination of both would be good. So when you talk about doing your aerobic or exercises to lose weight, you know how difficult it is to burn that 200-300 calories, right? I know, Leonard, you go for your high rocks and your exercises, right? So you know how difficult it is to burn that amount of calories. So it is not easy. Yeah, your one packet of nasi lemak, your one bowl of curry mee is already easily 10, 12 kilometers kind of jogging. Yeah, that's a lot of effort. So exercise is not able to replace healthy eating, but it's a very good supplement. So for example, when I talk about calorie restriction, I say you can eat only 1,500 per day. 1,500 is so difficult. What if I give you a bonus of extra 200 to 300? It's easier to achieve that target, right? So exercise helps you to do that. And of course, if you're able to build muscles, they increase your basal metabolic rate higher. Yeah, so you're able to burn more fats even at rest, right? Treat it as some form of compounding interest, in a sense. Yeah.
Right. So, in the exercise community, a lot of people love to strength train. A lot of people don't like to do cardio. CrossFitters. And in such a context, right, is there actually any good merit to say that, no, actually cardio is important because it gives you some cardiac protective benefits?
Yeah, I think circling back to what Chiew mentioned earlier on, there's good amount of data to indicate that, cardio exercises or aerobic exercises to at least 150 minutes per week has been shown to be beneficial. And the reason for that is because of its beneficial impact on blood pressure or blood pressure control, as well as on the reducing insulin resistance at the tissue level. So as a whole, that improves the cardiovascular health. So absolutely.
Right. So clearly there's a benefit right there, right? However, when it comes to a good thing, is there such a thing as too much of a good thing? Is that too much? Can exercise be harmful if you do too much of it?
Well, that's a difficult question to answer. But what my point of view would be, you want to start off anything, do it gradually. Yeah, give your body time to adapt. So you're not going to just run a marathon at 42 km when you just want to get started. You're going to start like maybe a few km first. Then after that, you slowly build up your base mileage and subsequently increase your distance. So I would say that in terms of starting, always start slow so that it is consistent, it's very doable. You don't need to hurt your body too much. I got patients whereby they go for those spin classes day one. They go it so aggressively, they have muscle breakdown and can affect the kidneys. Yeah, so start gradually and build it up from there. But if there's too much, I think you need to ask Dr. Thurston, is there such thing as too much of exercise? Yeah.
So for cardiologists, we are aware of a condition called athlete's heart. This is particularly seen in some endurance type athlete. By and large, I think exercise is good. Don't get me wrong. The athlete's heart is a condition where the heart muscle undergo certain adverse changes at the muscular level that results in some form of patchy scarring within the heart muscle, and then that results in possibly enlargement of the cavities of the heart. But again, I think, don't get me wrong, it is mainly seen in some endurance athlete, but not in the general population where exercise is done correctly in moderation.
Yeah, that's certainly not an excuse for most people to get more physically active at the end of the day, right? So I think we've briefly alluded this, which is exercise, there are different categories, right? But is there an ideal distribution one should start off with when it comes to the choices of exercise they do? Is there a proportion where a certain exercise, let's say strength, should take center stage compared to cardio, or vice versa?
Well, I think it's up to the individual's preference. As long as there's a good mix of both, I think you're good to go. Some people like more muscle building, by all means, go ahead for that. Some people like more cardio. They like to do your marathon cycling. Yeah, by all means, go ahead for that. But do remember to mix around with the other groups of exercises so that you get a more balanced form of physical activity.
Right. So a mixture at the end of the day
Yes.
is probably what's more important. So I do have to ask this critical question, which is, unfortunately in the news these days, you do hear of the unfortunate scenario where a seasoned marathon runner collapses mid-run, or a badminton player collapses and then unfortunately passes away from sudden cardiac arrest, right? What happened there, right? What is sudden cardiac arrest, and are there any screening, are there any warning signs for people, listening in today to be aware of that?
I think these are outlier events. They are isolated, but they gain media attention because they are dramatic in nature. I think that's important to frame my answer in that context. Now, some of these may not necessarily be everything. One thinks it's a heart attack, there must be a blockage, a plug rupture, and etc. Some of these are rhythm associated, and that's to say that for one reason or another, an abnormal series or sequence of heartbeat comes in, usually in the form of extremely fast heartbeat, or tachyarrhythmia as we call it. And some of these may be fatal in nature because then you lose cardiac output, your blood pressure drops, you don't get perfusion to the brain, and then things happen from there. So whether that's a sudden cardiac arrest that is revived or sudden cardiac death in its worst form. So as a cardiologist, the general advice and the best advice probably I can put to the public out there is this. Number one, if you have underlying known cardiovascular disorders, speak to your cardiologist with regards to whether it's safe and sensible for you to initiate on certain exercise regime. For example, if you've just had a myocardial infarction or a heart attack, as we call it, it's important that you build yourself up gradually. Your cardiologist may talk to you about undergoing what we call a cardiac rehabilitation program, where exercise is built up in a graduated manner. So that's number one, if you have established cardiovascular disorder. Number two, if you have family history of cardiovascular problems, whether that's sudden cardiac arrest, sudden cardiac death, or very strong family history of heart attacks, perhaps a screening prior to some form of more intense exercise is sensible. Number three, of course, if you have prior symptoms, for instance, shortness of breath, palpitations, or chest discomfort with exercise, then get yourself screened prior to exercise.
Right. And I want to touch a bit more about the symptoms you've mentioned, right? A lot of people that I've spoken to in the sports domain don't quite understand how does a palpitation feel like. But everyone's a bit shaken and concerned with the news. So mid-exercise, shortness of breath, I guess you can't breathe that easily, but how would you describe the symptoms that people should look out for and stop and seek medical attention?
So generally the symptoms that you need to be aware of is, again, number one, sort of chest tightness or a sensation of compression in the chest that comes on with exercise and then goes away when you rest. That's number one. Number two, palpitations essentially comes in two forms. There are some patients who feel the pounding sensation in the chest, but not necessarily rapid sensation. Most of these tend to be okay in terms of normal heartbeat or normal heart rhythm on further checks. But there are also the other forms where heartbeat is rapid, disproportionate to the amount of exercise that you're doing. So that would be more of a red flag to me. Number three, I think if you are already an avid runner or frequent exercise type of person, a drop in performance or your exercise capacity, that's again another red flag that may signify something brewing in the background. And if I were to circle back to what you mentioned earlier on, marathon runners dropping and etc., it is important for us to bear in mind that fitness in terms of exercise capacity does not in itself equate to absence of disease.
Right. It carries inherent risk.
Yeah, well, you got to look at your whole profile in other ways, your lifestyle and etc. That may confer you certain risks.
Right. And so I guess, you've eluded this point here, but I want to end on this really important note, which is the fact that for many patients, they've gone through a adverse event, whether it's a heart attack, or they've been newly diagnosed with type 2 diabetes, and now they're motivated, right, to lose weight. And sometimes then they go straight in, they injure themselves, and their weight loss goals derails off. They've in fact gained weight instead. So I know you've mentioned about cardiac rehab already, but from a metabolic standpoint, is there any rules or any practical advice you give patients on how they should actually get started? Is there something that people can take home today as a really easy rule that they can follow to get started into exercise?
I think circling back to what I mentioned earlier, weight loss journey is a marathon. It's not a sprint, right? Do small sustainable changes, things that you know you can do it for a long period of time. So those changes in diet, those exercise, don't do drastic changes that you know you cannot sustain it over a long period of time. You know, they say it takes 21 days to form a habit, right? So let's just start from there. Yeah, don't need to be too aggressive about it. Yeah,
Yeah,
then you build up from there.
just chime in on there as well.
Yeah,
I think the concept perhaps would be that, built in physical activity into your daily routines.
Yeah.
The little tweaks can come in terms of, taking the stairs instead of taking the lift. Parking a little bit further away and walking to the office rather than finding the nearest spot to where you need to come off. So, or taking the steps at the LRT station, for instance, rather than the escalator up. So these are little tweaks that will get you started if you're an uninitiated person. Yeah.
Right. So that extra steps may not be as annoying as it is actually more beneficial for you at the end of the day. Yeah. Just to kind of wrap things up today, I want to just give the floor to both our doctors today to just leave a key takeaway message. And maybe we can start with Dr. Thurston first. What would you like the public to remember from our session today?
Well, I think first of all, the key message number one would be that if you have any concerns, whether that's in terms of symptoms, what you feel, and I've mentioned quite a few earlier on, chest tightness, shortness of breath, palpitations, change in terms of your physical performance, that would be a cause of concern, and get yourself checked or screened. Or if you have family history of conditions that predispose to heart problems, for instance, diabetes, high cholesterol, and also issues in terms of weight, I think it's important to get yourself checked, at least to establish a baseline going forward. Number two, I think we've mentioned that weight loss is important, but it's also important that it's done in the correct manner. And if you're thinking of pharmacological or medication-based strategy to lose weight, it is important that it's done safely and in a monitored clinical situation or scenario. And number three, I think we've also mentioned that exercise is important, but extreme exercise can also bring about dangers. And I suppose at the end of the day, moderation is key.
All right. And Dr. Chiew, yourself?
So I think it's important for young people to realize that they're not shielded from non-communicable diseases. Just because you're young does not mean you will not have those conditions. Like I mentioned earlier, those between the age of 20 30 years old, 84% of them with diabetes do not know that they have diabetes. Yeah. So get yourself screened, even though you feel that you are well. Yeah, and if you really do detect you have issues with your health, such as diabetes, that's not the end of the world. In fact, that's a golden opportunity to do something about it, because I would like to treat you when you are diagnosed with diabetes on day one, rather than 10, 20 years later when you already have developed complications. Yeah, and when we do intervention for diabetes at such a young age, we're not just talking about controlling diabetes. It is possible to induce something called diabetes remission by virtue of weight loss. Yeah, so it is really a golden opportunity to do something about it. And lastly, lifestyle remains the core for weight loss. Yeah, our diet as well as our exercise. But it is okay if you're struggling to lose weight and need some help from medications. Yeah, because I think a lot of us struggle from that. However, if you do need medications, do not take it from unverified sources. Do not take it on your own. Do it under supervision of a healthcare professional so that you can be done safely. Yeah.
Right. Dr. Thurston, Dr. Chiew, it's been a pleasure. Thank you.
Thank you.